Okay, so welcome everyone who's just joining us to room one in the Data Plus track. It's our third presentation of the session. We're very happy to have Group 15, Mental Health in the Justice System in Durham County, sort of a long-ranging collaboration Data Plus has had with different entities in Durham, and this is another great shot in that series. So the format we're going to do is as before. They're going to talk for between 5 and 10 minutes. If you have questions during the presentation, please put them in the chat. Otherwise, as soon as they're done, please don't be shy. Unmute yourself and or put questions in the chat as we go. And go ahead and take it away, Group 15.
Hello, everyone. I'm Matthew, and I'll be giving the introduction. Individuals living with mental illness are overrepresented throughout the criminal justice system at the local level, where they can often be repeatedly booked and detained, often for misdemeanor crimes. The Durham County Detention Facility, or the DCDF, is the focal point for criminal justice contacts in Durham. And in recent years, the Durham community has taken steps to decrease the number of people who pass through this facility, including through the implementation of a crisis intervention team, the work of the county's Criminal Justice Resource Center, and the establishment of a mental health court. Coexisting in Durham are Duke Health and the Lincoln Community Health Center, which are two of the healthcare facilities in the region. From January 2014 to June 2015, a mental health tag was applied to the records of individuals who had severe mental illnesses passing through the DCDF. This tag was applied by mental health care professionals who were associated with the facility with the purpose of alerting the staff to the specialized needs of these individuals. And the tagging was discontinued due to HIPAA concerns. However, it remains a potentially useful indicator of the presence of individuals with severe mental illness who went through the DCF, and it was the focus of much of our research this summer.
So to explore some of the topics that Matthew has explained, we first completed training and we were granted access to data from the DCDF and data from Duke Health and the Lincoln Community Health Center. And the full data set from Durham County Detention Facility included about 23,600 unique individuals who were confined in the DCDF between January 2014 and January 2019. These individuals were matched with Duke Health and Lincoln Community Health Center patients, and they were de-identified before the data was transmitted to our team to ensure patient privacy. Our population of interest includes about 14,700 unique individuals who were booked in the DCDF and who saw a healthcare provider between January 2014 and January 2019. And then within this population, we analyzed a subset of about 6,600 unique individuals who were confined between January 2014 and June 2015, which was when the mental health tag was reliably applied. A big part of our summer was cleaning the data to fit our needs. We encountered several challenges in this process. We cleaned the data to fix cases where an individual had duplicate entries with conflicting race, sex, or mental health tag status to avoid double counting. We also addressed issues of erroneous negative incarceration links, and we consolidated encounter level and person level diagnoses using ICD-9 and ICD-10 codes. So using these clean data sets, we generated descriptive statistics and completed data analysis to illustrate the demographic profiles of our population, explore individual projects, and communicate our findings to our community partners.
We will do a rundown on the various projects that we have been working on this summer. If there's one particular project or section that you are interested in, let us know and we can zoom in and answer any question. So we worked a lot on generating descriptive statistic for our data. And so one project was to add the summary statistic for nicotine usage and suicidal self-harm diagnosis. We found that there's higher frequency of both diagnoses in the individuals with a mental health tag. Additionally, we took a dive into the emergency department usage. We examined the emergency room usage between individuals with a mental health tag and individuals without a mental health tag. We found that individuals with a mental health tag have a higher median of the number of ED encounters. We also examined the type of encounters in the ED and found that individuals with a mental health tag have a higher percentage of behavioral health related encounters in the ED. Not just looking at the amount of ED usage overall, we also examined ED visits in relation to arrest events. We found that individuals with a mental health tag have higher utilization of the ED in all time intervals before arrest than individuals without a mental health tag. Of the group with a mental health tag, utilization is highest within 1 week of arrest, whereas for the group without a tag, utilization is highest in the period between 1 year and 90 days before an arrest. Overall, 58% of the individuals without a mental health tag and 89% of individuals with a mental health tag had at least one ED visit within 1 year of an arrest.
In addition, by looking at descriptive statistics relating to incarceration broken down by sex, we were able to find that on average, the male subset of the population tended to have longer lengths of incarceration than the female subset. In addition, by looking at the descriptive statistics relating to mental health and substance use diagnoses broken down by sex, we were able to see that within our population, female individuals tended to receive more mental health and substance use diagnoses than male individuals, except for diagnoses of schizophrenia spectrum disorder and alcohol use. This is consistent with prior knowledge of mental health and substance use diagnosis trends. Moreover, by looking at the descriptive mental health and substance use statistics from a slightly different angle, by breaking it down by patient living status, so whether a patient was alive or deceased during our study window, we were able to see that the prevalence of mental health related diseases, bipolar disorder, major depressive disorder, and all substance use disorders of interest is higher among those who were deceased during the study window compared to those who were alive. It's indicated that the deceased population is especially vulnerable to opioid use and alcohol use, whereas the widest gap exists the widest gap in percentages of diagnoses observed. So we're also really excited to be continuing this work over the course of the upcoming academic year as a BAS Connections team. And from that jumping point, we'll be shifting from descriptive statistics to model building to help address some of the specific questions that we have received from our community partners, such as whether individuals who access Duke Health and Lincoln Community Healthcare Services are less likely to return to jail, and looking at trajectories in and out of jail and healthcare facilities using survival analysis. Thank you all so much for attending our session. Again, we know that our poster is very small currently, so just let us know and we can zoom into any specific sections.
Thank you all, that was great. People, don't be shy, questions in the chat or just unmute yourself.
We went over a lot in our presentation. So yeah, if you have any questions regarding to like a specific figure, like Seymour figure 3, like we can definitely zoom in and then discuss more about what our thought process and what we learned from the various figures and our individual projects are.
Yeah, if you zoom in just a little bit more, I think. There you go, perfect. Oh, let's see. Hold on, I think we have a comment in the chat. Let's see. So David, can you clarify what you're saying there?
Oh, I mean, I guess this is just more of a visualization question. It's like when I first looked at overall at the chart, it's a little hard to see some of these like interactions that you're talking about with gender, and then you're using that light blue and dark blue for everything.
Yeah.
Thank you for your feedback.
Yeah, I see what you mean. What we were trying to do with that was just have a consistent color palette, because we did break it into so many different groups that there would have been like 16 different colors across your poster. And visually, that's also had its own drawbacks, because then it sort of became a bit more convoluted with what each was sort of looking at. But I see what you mean in that because the key is giving different indicators, that could be confusing.
Yeah, it's a tricky issue. Did you have much interaction with folks at the jail or the hospital in these conversations, or was this kind of a data dump and then analysis?
We had a lot of contact with the county CJRC, or the Criminal Justice Resource Center. That they were sort of our contact point with institutional support regarding how the criminal justice system works, especially in relation to local jail incarceration within Durham.
And I'll chime in on this one. This is Nicole Strabes-Pato, one of the faculty co-leads. We're going to be having more engagement with the jail folks over the fall semester.
Okay.
Got some good back and forth.
Is this continuing into Bass?
Yep.
Okay. Thanks.
Yep.
Cool. Let's see. Here's a question coming in. Morgan Beal says, how do you hope this data can inform or make changes to the health or justice system, or both?
I think that one of the biggest things that I've learned over this process is that there's a pretty predictable pattern of people seeking care for mental illness and sort of attention to that aspect of their health before an arrest, which is what we see in some of the figures in the fourth column. So I think that just having a stronger link between mental health care services and the jail is extremely important to try to help people sort of where their actions are asking for help, meet that with the resources that we see can be helpful.
And then Susan Goodman asks, what does mental health treatment mean? Drugs, talk therapy, group or individual therapy, referral patterns. Do people who seek mental health care in fact get it?
For our analyses, what we were using as our baseline for mental health treatment is based off of the ICD-9 codes, as Liz mentioned. So this comes from the billing information from the hospital. So this can actually encompass a wide breadth of different services that people will go to. And in the second question regarding whether people who are seeking mental health care are in fact getting it, that is something that we're really looking to exploring in our Bass Connections team through the rest of the year, looking at the specific cases of where people with mental illness go to the emergency department or the healthcare facilities, and then how that affects their trajectories with interactions with the justice system.
Yeah, and I'll chime in to say that we don't have a record of what they were, well, we do have chief complaint, but we don't have detailed records of what they were seeking when they showed up at the emergency department. And then the bigger data set that we have not yet analyzed is when they go to a mental health treatment clinic, which ones are going to a mental health treatment clinic. That's in the future to be analyzed.
Yeah, one comment I'll make here is that the all of the wonderful protections for patient privacy, which obviously should be there, are also a wonderfully frustrating obstacle to exactly these kind of trajectories, where you can have someone be anonymous at the jail and then you want to check whether they actually got to the clinic, but they have a different identifier over there. And so there's so much back-end horrifyingly crunchy work that is just, can you literally link an anonymous person from one place to the other? And obviously you want them to get from one place to the other, and often they don't because they're in crisis. So it's one could write an essay about the good and the bad of HIPAA there. So Morgan Beal asks, will there be outlier data from this year because of COVID changing normal health service usage? Is telemedicine involved, I guess, in your data?
The current data that we have is from 2014 to 2018. So I don't think we'll have problems with the current data set that we're working with. But more generally, there are, within our healthcare data, we do have entries for people who used telehealth services.
And I would also add that when we met with the director of the Criminal Justice Resource Center, she said that the capacity in the DCDF is actually at its lowest in over 20 years due to COVID. And that was something really interesting to me, is sort of how the jail is dealing with COVID. And the director expressed sort of this idea of wanting it to sort of stay this way. Like if people don't need to be in jail, like why not reduce capacity there too?
Yep. See, other question. Other questions folks have?
I guess as a follow-up to Susan Goodman's question, asking about if we can find out how many hours of treatment they in fact got, as Nicole mentioned and hinted out, we don't have you know, the breakdowns, like exactly what was happening. We just have the chief complaints of the visits. And the caveat to all of this is that we only have health data from the Duke Health System and then another community partner, the Lincoln Community Health Center. And Lincoln Community Health specifically works with those who have low access to healthcare facilities. However, because we don't have, you know, like the entire health profile of these individuals, we are cautious with all of our observations and a hypothesis to acknowledge that we're limited by the fact that we only have certain subsets of healthcare information available.
Other questions? Yeah, I mean, as I often say throughout the semester, I hope people leave Data Plus realizing you can never say the data speaks for itself. You can also never say, and that's obviously what you're seeing here. And you can kind of never ignore politics in data, politics sort of with a small p, in that the fact that this data exists means that the jail and the health system are talking to each other, right? Which took some doing. Anyone have other questions? Here we go. Let's see. So Susan asked, did people referred for mental health bounce back into the criminal system? Are you able to track that at all?
That's our primary focus for going into the fall, what we're going to be looking at, but just from the preliminary statistics regarding just like the summaries that we have a pretty good sense that people who are getting mental health services are what the Criminal Justice Resource Center referred to as like frequent visitors into the detention facility, so that and these individuals are more likely to be committing misdemeanor crimes, but we're still seeing that even when they are getting, you know, they're being seen in the Duke Health System for mental health reasons, they're still being booked into the DCDF again at a later date.
So your data ends in 2018, right? Full stop.
It goes until January 2019, but yes,
2019. I mean, in a way, it's unfortunate because you have you know, with all the different debates about criminal justice reform and so on, you sort of have a natural experiment, which is that the DA and the sheriff changed in 2018, and either that had an effect or it didn't. You know, people say things in elections, but who knows? And so, but you're not going to be able to see that because it's stopping right there.
To add into what Matthew said, so at the beginning of the summer, one thing that our project manager was really emphasized on is sort of like focusing on like personal narrative before zooming out and looking at the data and the trends. And so why doing like personal narrative, like just I guess like we do see on the personal level that there are people who are referred for mental health or goes to Duke Health System for mental health, and then in the future after I guess the medical encounter, they are still they do have contact with the criminal justice system. So on the personal level, we definitely see examples to where people who are referred for mental health does bounce back into the criminal system.
Some context I should provide for people wondering about the fall. Duke has a program called Bass Connections, which is team-based work, not intense full-time, but sort of as a class, which continues throughout the year. And often Data Plus projects continue into them, and often Data Plus projects come out of Bass Connections. So it's a good exit ramp. Other questions? I guess I'll ask you all the same stop question you heard me ask the other groups if you were on, which is, what did you not know how to do that you now know how to do technically?
I can tackle this one first. So for me, I took Statistics 199, which is Intro to Data Science. So we were given lots of problem sets to work with data, but sort of dealing with missingness and different data cleaning aspects in the problem sets always seems sort of like I was just doing it to get my homework done. And now that we actually have really huge implications for this data, I found that we would spend hours talking about if we should exclude someone or if this missingness should be handled in a certain way. And I just got a whole new perspective on data cleaning after getting more personally connected to the data sets.
That's neat. Yeah, the way I always feel about missing data is it feels completely inappropriate to make any sort of choice, and it feels completely inappropriate to ignore the fact that the data is missing as well. So.
I guess I can jump in. For me, I would say out of the team, I'm the person with like zero experience on like coding or like R coding, as a lot of Data Plus participant. So I think it's just such a unique way to learn computer language, like learn R. I just think it's super meaningful, and it's like very motivating and gratifying. Like Nick said earlier, how you just like learn this tool knowing that there are potential impact to like learning the tool, and it's really nice to see that when you learn something that is applicable to, I guess, like service. I think it's really awesome way of learning.
Cool.
Yeah, and I will add on to sort of echoing the comments that Bella made about the data cleaning, but just going through every step of our analysis and always having to take that step back and looking and thinking about, well, how is this data collected was a big question that we had throughout our research, because obviously the data coming from the detention facility or reasons for arrest coming from the police officers, we know that this data is going to have biases in it, but we're not sure which way these are going to go in various circumstances. And realizing that the decisions we make, how we classify variables within our tables, or even just how we express them in visual formats, we have to be cognizant of the way that this data was collected, because we're never seeing the whole picture.
I'll just say, I think you would go far writing blog entries and saying exactly that sort of expression a lot. There's a stereotype of data scientists, I think, where because algorithms are taking over and they have such biased results, that data scientists kind of put their heads down and don't think about any of this. And it seems to me sort of generally just not true. I think people struggle with these and it really pains them. So there are no answers, and the fact that you think about it doesn't mean that it still isn't appropriate to use it sometimes, but the more you can express that, I think the better. Other questions folks have? So Susan asked, what implications for policy?
So I don't know, I'll jump in. That's a big question that we've all sort of been thinking about. And I know for me, I'm really glad to have another year to be thinking about that question as well. But I think the first thing that we sort of learned and that we've been talking about a lot as a team is that like sort of the wide reaches of the criminal justice system and its impact lying like much further outside of the jail, and sort of how, in addition, how the jail can be used in like multiple different ways, and how we can see that in some cases it's sort of used as a way to like almost as if like our society, I guess, is criminalizing some mental illnesses. And I think that by increasing the awareness and like the data behind these patterns of people coming in and out of the jail who have mental illness could improve and sort of take away from that cycle of people just ending up going to jail instead of treatment and cycling back.
Yeah, to add on to that, I'll just, like in this figure that we created, sort of looking at individuals, the ones who are tagged with the mental health and not, and the fact that, you know, we have such a high percentage of individuals who have a mental illness who are having an emergency department visit a week before their eventual arrest. It's sort of showing that even this is not just a problem on the, you know, the police or the DCDF side, but we have these individuals who are going to an emergency department visit, and what is the care that they're getting, which is meaning that they're still going to be arrested within a week after they've had this emergency department visit, and sort of making sure, you know, obviously we don't have like, you know, the exact policy laid out, but this idea that these people are somehow falling through the cracks of the system and they're being seen for an emergency department visit, but then they're still ending up in the criminal justice system.
And to add on to Matthew a little bit, I think one thing that our work can reflect is the connection between emergency care and the justice system a lot. So in figure 6, Matthew looked at the ED usage before an arrest event, but I know there are literature out there that studies sort of like overdose encounter in emergency department after like a patient get released. So there's like a lot of potential for us to make connection between like emergency usage and the justice system, which is really awesome.
So I hate to cut off really good discussion now, but just want to flag that people who are looking to jump to another session should do so and wrestle with Zoom because it's 3 minutes. Let's have this group unshare their screen, and group 25 go ahead and share. And I believe Becky asked a question to take you out the door, which is, do you consider yourself data scientist now, or is it going to take another year?
I'd say it's going to take another year. There's always more to learn. And if anything, this project showed however much you think you know about data cleaning, data science, there's always a lot more to learn.
Yeah, that doesn't go away. Okay, so we'll start again at 3.